This video is available in 21 languages. यह वीडियो 21 भाषाओं में उपलब्ध है. To change the audio, go to settings, click on the audio track and choose your favorite language. ऑडियो बदलने के लिए सेटिंग में जाएं, ऑडियो ट्रैक पर क्लिक करें और अपनी पसंदीदा भाषा चुनें.
Bipedal locomotion demands a highly specific mechanical compromise. The human skeleton must continuously support massive compressive forces from the upper body, while remaining flexible enough to allow for energy-efficient movement over long distances. To achieve efficiency during a standard stride, the body alternates between gravitational potential and kinetic energy. At intermediate walking speeds, this transfer provides up to 70% of the total energy required to move, leaving only 30% actively supplied by muscles. Classical anatomy attributes the hip's ability to manage these forces almost entirely to its bony architecture. As a deep, congruent ball and socket joint, the interaction between the femoral head and the pelvis is widely considered to be the primary source of stability. Because of this focus on the bone, many models reduce the surrounding hip capsule and its ligaments to secondary status. They are frequently depicted as thin, static restraints that sit in the background, only engaging at the extreme end ranges of motion. This structural view has created a clinical challenge. Modern patients undergoing successful arthroscopic surgeries with a fully intact bony ball and socket are presenting with rising micro-instability and chronic postoperative pain. The source of this instability lies in a systemic misclassification of the anatomy. The hip's soft tissues, spanning from the inner labrum out to the thick iliofemoral ligament, actually form a continuous, dynamic kinetic energy transfer system that coordinates movement. Re-examining this microarchitecture suggests that treating these tissues as passive coverings may explain why many joint repairs fail to restore full function. To understand the burden placed on these soft tissues, we have to map the forces crossing the joint. During a single leg stance, the effective center of gravity shifts away from the supporting leg. This creates a mechanical imbalance, pitting the long moment arm of the body's weight against the very short moment arm of the abductor muscles working to keep the pelvis level. Because of this unbalanced lever ratio, the abductor muscles must generate a force multiple times the actual body weight. During unexpected events like a stumble or the loading phase of a sprint, the resulting compressive vector driving the head of the femur into the socket can exceed 8 times the person's total body weight. While the bone absorbs that compression, athletic movement simultaneously subjects the hip to severe distraction and torsional forces that attempt to pull the joint apart. The bony socket is not oriented to resist these pulling forces on its own. Instead, the hip relies on a specific structural countermeasure located deep within the capsule, the Zona Orbicularis, or annular ligament. Rather than running from bone to bone, the fibers of the Zona Orbicularis are circular. They form a distinct physical collar that wraps entirely around the narrowest part of the femoral neck. This collar reacts to muscular load. When the deep iliopsoas muscle contracts during hip flexion, the Zona Orbicularis tightens. It acts as a mechanical locking ring, cinching the joint capsule down around the femur. This active musculo-ligamentous synergy holds the joint together under tension. Resistance to distraction is a highly coordinated dynamic process rather than a result of passive bony depth. Moving inward toward the rim of the bony socket, the joint is lined by the labrum. This is a wedge-shaped ring of fibrocartilage that attaches to the circumference of the acetabulum. At the very bottom of the socket, where the bone features a natural notch, the transverse acetabular ligament crosses the gap to complete the full circumference of this fibrocartilage ring. By bridging the transition between the bone and the soft tissue envelope, the labrum performs a specific biomechanical role. It functions as a gasket, establishing a negative pressure seal tightly around the head of the femur. This vacuum seal restricts the movement of synovial fluid out to the peripheral compartments, keeping the joint lubricated and suctioned into place. Sustaining this tissue requires a dedicated blood supply, provided by branches of the obturator and gluteal arteries. But this vascular network is constrained. The arteries ascend within the reflected synovial layer of the capsule and only penetrate the outer peripheral 1/3 of the labral tissue. Moving deeper into the joint, at the internal margin where the base of the labrum directly interfaces with the smooth articular hyaline cartilage, There is a complete absence of blood vessels. This avascular zone is known as the watershed region. Because it lacks any blood flow, this highly stressed junction possesses zero intrinsic capacity to heal itself following a degenerative tear. The labrum and the internal structures are enclosed by the joint capsule. For decades, medical illustrations have depicted this capsule attaching to the pelvis in a thin, neat line bordering the rim of the socket. Recent micro-CT imaging and histological analysis have challenged this mapping, proving that the scale of the soft tissue connections is much larger than previously recorded. The capsule's footprint on the pelvis is expansive. It reaches high onto the inferior area of the anterior-inferior iliac spine, filling a wide space bordered by the surrounding musculature. This wide footprint does not sit in isolation. The capsular tissue spreads outward, physically blending directly into the deep aponeuroses of the adjacent hip muscles. In human biology, bone responds to physical demands through remodeling. When connective tissue applies heavy, repeated tensile stress to an anchor point, the underlying cortical bone thickens to handle the load. Micro-CT and histology of the iliac spine confirm this. Heat maps reveal cortical bone thickening directly beneath the wide capsular attachment zone. Here, the fibrous capsule anchors into bone using dense calcified fibrocartilage built to withstand mechanical shear and tension. Surgically detaching this area severs a mechanically adapted stabilizer, one structurally identical to the origin point of the strongest ligament in the human body. That ligament is the iliofemoral ligament, which spans the anterior capsule. Traditionally, it is classified as a simple passive tether, with the sole job of preventing the hip from hyperextending. The reality of its architecture is more complex. The fibers of the iliofemoral ligament integrate directly into the deep aponeurosis of the main hip flexor, the iliopsoas. Moving laterally, the ligament creates a secondary structural blend, fusing directly with the gluteus minimus tendon at its attachment on the superolateral end of the femur. To test exactly how this interconnected tissue affects human movement, researchers at Cambridge University constructed a detailed musculoskeletal simulation to measure its role during bipedal ambulation. The simulation measured the mechanical work required by the hip flexor muscles to perform a normal walking stride, both with and without the presence of the iliofemoral ligament. This chart shows the required muscular work of the iliopsoas and sartorius muscles. The data reveals that removing the iliofemoral ligament from the equation nearly doubles the active work required by the hip flexors simply to walk. By bridging the muscles together across the joint, the soft tissue operates as an elastic spring. It absorbs load during extension and provides kinetic energy return to assist the muscles during flexion. The iliofemoral ligament is a dynamic kinetic synergist. Preserving its structural integrity is required for maintaining the energy efficiency observed in human bipedalism. The hip is a continuous engine. The labral seal manages fluid pressure. The Zona Orbicularis provides distraction locking, and the expansive capsular footprint anchors the kinetic chain to the pelvis. Woven through this foundation is the iliofemoral ligament, feeding kinetic energy back into the surrounding musculature to maintain an efficient stride. This interconnected reality contrasts with common surgical practices. Procedures such as labral repairs or bony decompressions of the anterior-inferior iliac spine often mandate cutting a pathway through this exact capsular tissue. Executing a capsulotomy without accounting for the kinetic chain severs a highly tensioned network, instantly releasing the elastic potential of the surrounding fibers. Leaving these capsulotomies unclosed or only partially repaired can disable the kinetic energy return mechanism of the anterior hip. The consequences are measurable. Without this elastic assist, the hip flexors and abductors must take on a permanent increase in mechanical strain during daily activities. This cascade of muscular overload and lost tension explains why many patients experience micro-instability despite their bony joint being fully intact. Protecting the hip's efficiency requires a clinical commitment to the soft tissue envelope. Meticulous handling and precise anatomical repair are necessary to preserve the biomechanical performance of the joint.